So today we'll see about this temporomandibular joint disorders. So temporomandibular joint is also sometimes referred as a craniomandibular joint or diarthroidal joint. Temporomandibular joint, which also sometimes referred as this, it needs to study, comes when the patient at your clinic with a problem of inability to open his mouth, close his mouth, or some kind of pain or discomfort is in his head or neck region. Technically, breaking through the various diagnostic studies have enhanced clinical ability to diagnose and treat this problem. Now, what are the disorders? So by definition, temporomandibular disorders refers to a cluster of the disorders characterized by following main symptoms: pain and tenderness in the region of the muscles of mastication and TMJ. It sounds during the condylar movement and limited or asymmetric mandibular movement. So the evolution is this temporomandibular joint, it grows during the that time. The development is about 10th week of intrauterine life. The components of the future joint shows that the first indication in the mesenchyme between condylar cartilage of the mandible and developing temporal bone. Two slit-like joint cavities and an intervening disc make their appearance in this region at 12th week. So the cranial component, mandibular fossa, which holds the joint, then mandibular component, okay, then temporomandibular joint capsule, its blood supply, nerve supply, etc. The diagnostic studies contains plain radiography, conventional tomography, arthrography, and computed tomography, magnetic resonance imaging, electromyography. Now, what are the various TMJ disorders? First is intra-articular origin or intrinsic disorders, such as trauma, dislocation and subluxation, hemarthrosis, intercapsular fracture, then internal disc displacement with or without reduction, arthritis, osteoarthritis and rheumatoid arthritis, juvenile arthritis, infectious arthritis. Now, then the developmental defects such as condylar agenesis or aplasia, condylar hyperplasia, condylar hypoplasia, ankylosis, neoplasms, benign tumors, malignant tumors, extra-articular origin, intrinsic disorders, masticatory muscle disorders, protective muscle splinting, MPDS, results of external trauma, fracture, traumatic arthritis, myositis, tendinitis, internal disc derangements. Dislocation, it is an excursion of the condylar head beyond the normal limit of the anterior slopes of articular eminence, which is viewed as to be abnormal, termed as dislocation. It is like this. This is a normal movement, and when it is a saddle-shaped structure, okay, it's eminence. So this is called dislocation, when the condyle head moves out of the socket. Classification is unilateral or bilateral, acute or chronic, long-standing. Causes: extrinsic forces or iatrogenic causes like a blow on the chin, injudicious use of mouth gags, excessive pressure on the mandible during mandibular extraction. Intrinsic or self-induced forces like exercising, yawning, vomiting, blowing wind instruments, and loudly laughing also. Clinical pictures and management of acute dislocation, the unilateral difficulty in mastication, swallowing and speech, continuous drooling of saliva, deviation of the chin to the contralateral side. Mouth is a part oftenly open and effective condyle cannot be palpated. Indefinite definite depression is seen here and felt in with the front of the tragus. This is the tragus. Front of tragus, you will feel the this depression of the affected side, and there is a muscle spasm also. In bilateral, pain and inability to close the mouth, tense masticatory muscle, excessive salivation, protruding chin, difficulty in speech, pain in the temporal region, hollowness can be felt in preauricular region, muscle spasm may lead to fixation of the condyle position, anterior open bite, gagging of the molars, drooling of the saliva. Management of acute dislocation, reassuring the patient, tranquilizer drugs, pressure and massage to the area, sedative drugs, manipulation without anesthesia and with local anesthesia, or sometimes you require general anesthesia also. Now this is the position you have to place. Can you see the position of the thumb? On the retromolar pads, okay, or the posterior teeth, posterior-most teeth, and by all four fingers you have to grip the jaw, and then slightly posterior and downward movement so that the condyle, downward and posterior movement so that the condyle will slip into the glenoid fossa again. Management of chronic recurrent subluxation. First is intermaxillary fixation, use of sclerosing solution, surgical approach, capsule tightening procedures, which includes capsulorrhaphy, placement of vertical incision, reinforcement of the joint capsule, creating mechanical obstruction sometimes that so that it should not come out. It is stopped by the mechanical obstruction. Then direct restraint of the condyle, creation of the new muscle balance, removal of the mechanical obstacle, meninxectomy, high condylectomy, eminectomy, ankylose of TMJ. Then ankylose is a Greek word. It means as a stiff joint. It may be defined as a pathological fusion of the two articular components of temporomandibular joint, which leads to inability to open the mouth from partial to complete. Classification is falls to ankylosis, extra articular or intra-articular, fibrous or bony, unilateral or bilateral, partial, complete. Now the ethiopathology contains trauma, congenital infections, rare causes such as systemic disease and other causes. Clinical presentation contains for a unilateral TMJ ankylosis, obvious facial symmetry can be seen, asymmetry can be seen. Then deviation of chin to the affected side, because by affected side, in subluxation, the chin will go opposite side. And in this ankylosis, the chin will go towards the affected side because that joint is not grown. Okay. The chin is receded with hypoplastic mandible. So the roundness and fullness of the face on the affected side, flatness and elongation to the affected side, well-defined antigonial notch, some amount of oral opening, crossbite may be seen, angles class 2 malocclusion on the affected side, condylar movement are absent on the affected side. In this, you can see this is the affected side. Everything is flat here, and this is the normal side. So obviously, this is the shorter one. So the chin will deviate towards the shorter side. In bilateral inability to open the mouth, typically bird fish deformity, neck chin angle may be reduced or complete absent, well-defined antigonial notch, Class 2 malocclusion, anterior open bite, sometimes carious teeth with bad periodontal condition, severe malocclusion. Okay, classical clinical feature of a bilateral TMJ ankylosis. Treatment surgery is the only treatment modality in case of TMJ ankylosis. Various surgical aspects include condylectomy, gap arthroplasty, interpositional arthroplasty, cosmetic rehabilitation. The post-operative physiotherapy and joint exercises is must in order to avoid the recurrence and normal interincisal opening. So approaches to the joint are pre-auricular approach, indural approach, post-auricular approach, radiatectomal and submandibular approach. So this is the classical extension of with the Elkite-Bramley modification here. Now this is a simple pre-auricular approach, and this is endural approach. Endural is posterior to the tragus so that the scar is not visible. So best is the reverse question mark or Elkite-Bramley incision so that the joint is exposed completely, and then gap arthroplasty can be done, and sometimes reconstruction of the condyle can be done with the costochondral grafts also. This is the on-table mouth opening achievement. We can achieve 30 plus mouth opening here. Complications are hemorrhage, pneumothorax, damage to the facial nerve, then infection, otitis of the or stenosis of the canal, or sometimes re-ankylosis also. Cosmetic rehabilitation, sagittal split osteotomy, genoplasty later on with distraction osteogenesis, sometimes maxillary osteotomies all are there. Now next disease is myofascial pain dysfunction syndrome. It is defined as a discomfort around the face and mouth that is induced by chewing and other jaw use, but is independent of local disease involving the teeth and oral cavity proper. Etiology exact cause is unknown, but yes, psychological and stress is a major factor. Environmental stress, muscular hyperactivity, which leads to muscular hyperactivity. The occlusal or peripheral etiology is also there. Sometimes dental cause or occlusal disharmony is there. So increase in the vertical dimension is there. So the patient, when the patient is closing the jaw, it gives direct pressure on the joint. Then intrinsic joint disorders, trigger zone. These points exist as a localized tender area with taut bands of the muscle, and when stimulated by an traumatic episode, they refer characteristic pain to the distal muscle as well. So they are called as zone of reference also. Palpation of these trigger points will give rise to the positive jump sign. Symptoms: pain of unilateral origin, pain is constant, diffuse, and patient is unable to identify the site. Pain is severe on arising in the morning or gradually worsen as the day progresses. Pain is exacerbated by use of mandible. Spread of pain from facial to cervical region and to the shoulders. Masseter is the most commonly involved, and pain appear as the jaw ache, temporalis headache, lateral pterygoid ear ache or deep pain behind eye, medial pterygoid discomfort, then discomfort while in swallowing or swollen gland behind the angle of mandible. Tenderness in the muscles of mastication, tenderness elicited by the examiner. Most common sites are angle of mandible, in the belly, posterior superior aspect of the masseter, and in the anterior temporal region, anterior aspect of coronoid process. The limitation of the mandibular movement is there. Correlated with the amount of pain present, if it manifests as inability to open the mouth as well as usual and as deviation of the mandible to the affected side during the opening. Lateral excursions are unaffected side, so it's also reduced. Clipping or popping sound of the TMJ, absence of clinical, radiological, biochemical evidence of pathological changes in TMJ. Associated symptoms are neurological tingling, numbness, sometimes twitching, sometimes GI problems, muscular fatigue, tension, weakness, pathological tinnitus, ear pain, vitiligo, and dizziness. Management in 3 components of physical health, general health, nutrition, age, then occupation and lifestyle, and psychological, ethnic background, social customs, behavior, emotional health, parafunctional stress. Dental in avoid the supra contacts or correct the dynamics, and largely means the correction of the occlusion, okay, and improper vertical dimensions. So proper patient history is taken, examination, physical examination, extent of the movement of TMJ, palpation, auscultation, then in muscular, dental, occlusal discrepancies and prematurities at region we have facets and missing mobile teeth, anterior open bite, cross bite, vertical dimension, then and cervical palpation also. In examination of TMJ, yes, go behind the patient. Then this is a palpation method. Go behind the patient and then palpate with the your fingers. Index finger will stabilize, and you will palpate the gliding movements with the middle finger. Palpation of temporalis muscle, masseter muscle, lateral pterygoid muscles should be there. Treatment based on the etiology of the treatment can be done. Pharmacological modalities, physiotherapeutic modalities, stress management, occlusal splints, and intra-articular injections, biofeed and relaxation therapy, psychological modalities, muscle relaxant, mostly centrally acting or periphery acting, like chlorhexidine and meprobamate, cyclophosphamide. Then anxiety agents such as alprazolam, diazepam, lorazepam, and flurazepam. And inflammatory agents like our normal salicylates and propanoic acid, acetates, and phenamates. Then pharozones, oxycams, and corticosteroids like glucocorticoid. Short-term application should be there. In occlusal splints, to create balanced joint tooth relationship, to reduce spasm, contracture, hyperactivity of musculature, to improve vertical dimension, safety or protective appliances, stabilization splint, relaxation splint. Physiotherapy modalities, acute or chronic problem, outcome should be measurable, data to monitor progress of the treatment. Electric stimulation such as TENS or iontophoresis, electroacupuncture, high voltage stimulation, medium frequency stimulation. Heat application like superficial or deep, increase oxygenation, increase membrane diffusion, efficient removal of the byproducts. Also improve the joint mobility also. Hot packs and paraffin are given. Deep heated diathermy. Then intra-articular injections of hydrocortisone can be given to treat the inflammation within the joint. For this, 2% of lignocaine with 0.5 cc can be mixed with hydrocortisone for relieving the purpose. Goal of the treatment is to reduce inflammation, improve range of motion, restore function and aesthetics. Conclusion, these TMJ disorders are not life-threatening, but their treatment relates to the improvement in the quality of the life. So the ultimate need is to have this. this, a doctor should be well versed with all the basic principles of the treatment to have best results in his work. So next time we'll conduct. Okay, so this concludes our TMJ disorders, mainly which can be preferred by in this clinic, and which we can examine in the clinic. Mostly in clinic, TMJ pain disorder patients, they come, not sometimes ankylosis patients, so we have to take them to the big setup or big hospital, because ankylosis can be done under general anesthesia. But for sometimes for MPDS, okay, and subluxation, these type of patients can be treated in emergency in our